With this spring having been the 20th anniversary since The Revenge of the Sith was released, I had thought about making a presentation on diagnosing the injuries sustained by Darth Vader in his battle against Obi-Wan on Mustafar, and discussing how I'd expect he would have been treated had he come here into our care at Kettering. But pragmatism ultimately won the day. So my scholarly presentation is instead going to be on thyroid function tests and common interferences that impact our clinical interpretation of these tests. Now, this particular topic came to mind a little bit after I encountered a patient with some unexpectedly odd thyroid function tests. Now, unfortunately, I couldn't find the exact case, but that really isn't important to this presentation today. What's important is that after discussing the case with the attending and bringing up my concerns about some very unusual thyroid function test results, which ultimately they weren't concerned about, I ultimately went home and looked up some causes of unexpected thyroid function tests and what it is that actually causes these aberrant values at times. So this presentation is really birthed out of that, and I hope that it proves both interesting and helpful for all of us as we encounter unexpected thyroid function test results in our future clinical practice. So just as a review, the image here is of a normal thyroid, and you could ignore the arrows as they're all pointing to a thyroid. There are two lobes on the left and right lobes, and they are connected by the isthmus there in the middle. And this is all sitting anterior to the trachea. Histologically, as you can see in this background here, the thyroid is moderately complex, and there are cells and groupings of cells that have different functions that they're trying to accomplish. However, in short, the job of the thyroid is to receive thyroid stimulating hormone, or TSH, from the pituitary gland, and after receiving that, trigger the release of thyroid hormone in the form of T3 and T4. As you no doubt remember, this thyroid hormone is released broadly into the bloodstream and regulates metabolism, increases protein synthesis, increases oxygen consumption in all cells of the body, and it is freely released into the bloodstream to do that. And not only that, but it also acts back upon the pituitary gland itself to tell the pituitary gland at a certain point to begin ignoring the thyroid releasing factor, or if you prefer, thyroid releasing hormone, which is of course part of the hypothalamic pituitary axis, and acts as a negative feedback loop to cease the production and release of these thyroid hormones. It is a highly fine-tuned mechanism to keep the levels of thyroid hormone at appropriate levels in the body when, of course, it is not in a pathological state. Now, risking the possibility of giving you horrifying flashbacks from medical school, I just wanted to remind you about the complex mechanism of thyroid hormone synthesis and the creation of both the prohormone, free T4, which of course is analogous to prescribed levothyroxine, and the active deiodinated triiodothyronine, or more easily said T3, which is the primary active form, causing the many physiological effects of thyroid hormone on the body. It all starts when TSH attaches to a TSH receptor on a follicular cell, instigating the release of thyroglobulin into the colloid.
It's magic! Ooh!
Fine. Let's just say that TSH and iodine are necessary, and in a physiological state, T4 and T3 are released into the bloodstream at a ratio of about 9:1. These three hormone levels can be measured, of course, and based on the patterns that result from that measurement, we can then make a diagnosis in concert with the clinical presentation that we see from the patient. This is a fairly typical chart of some of the conditions and some of the patterns that we see from thyroid function testing. The problem is that these assume normal circumstances, and sometimes we get results that fit these patterns, but we don't see the clinical symptoms that we would expect to go along with the corresponding condition. Worse yet, Oftentimes, this is the patient that spends more time than we do on their lab results page in MyChart and on WebMD, and they're now asking you what kind of cancer they have. So, all this to say, there is value in having some idea of what goes on behind the curtain in Oz, or in this case, in the lab. This device on the left is a chemiluminescent immunoassay analyzer, and among its many jobs is measuring a given blood sample's TSH, T4, and T3 levels. It works similarly to ELISA, which we all at least briefly heard about in medical school. When running thyroid function tests, this device performs what's called sandwich immunoassay, and what that means is this. There is a well that's in this machine, and that well is lined, the walls, the surfaces are lined with this capture antibody. The antigen is then separated from the serum and is added to the well, and ultimately these antigens bind to the antibodies that are lining the walls of the well. Another solution is then added with antibodies that are specifically designed to only bind to the antigen if it's already bound to the antibodies that line the surfaces of the well. It's important to note that for thyroid function tests, this antibody is biotinylated, or in some cases, ruthenium is used instead. A special enzyme is then added, and it forms the streptavidin HRP complex with the previously bound antibody antigen complexes. And as this occurs, it causes a flash of light with the chemical reaction that took place, that chemiluminescence in the name of the device. The degree of luminescence is measured by the machine and translated into a numeric value that quantifies the level of the tested for antigen within the sample. Now, technically for T3 and T4, it can be a bit more complicated, as there are additional ways that labs may come to the resulting values. But whether we have a solid grasp on the mechanism or not, the unfortunate fact of the matter is that no test is immune to error, or, as we're discussing today, to interferences. And while it's certainly not necessary for internal medicine physicians to understand the minutiae of these interferences, I believe it can be beneficial for a clinical physician to have an awareness of the existence of the more common interferences and when they might expect them. It's worth noting that this is not going to be comprehensive. If I had the time, I could go into other common scenarios where TFTs can be altered, many of which you're likely already aware of: pregnancy, medications such as heparin, aspirin, oral contraceptive pills, estrogen receptor modulators, some opioids. Similarly, liver or renal disease can affect the clearance of these medications or the analytes themselves. Even acute illness or more strange causes like congenitally abnormal hormone or protein production, any of these could also alter the correct value of the result for an analyte. We're not asking the question, what is everything outside of thyroid disease that can affect TFTs? What we're asking is, considering how chemiluminescent immunoassay analyzers work, what can make them work incorrectly? Or said another way, in what context should our differential include interferences? This image is another way to represent that sandwich immunoassay we just discussed previously. However, it not only shows each step or component of that immunoassay, but also points out where things can go wrong. And that's what we're discussing today. Our discussion will delve into several common interferences encountered in thyroid function testing, including macro-TSH, biotin, anti-streptavidin antibodies, anti-ruthenium antibodies, thyroid hormone autoantibodies, and heterophilic antibodies. The first of the interferences that we'll be discussing is macrothyroid stimulating hormone, or macro-TSH, which refers to a high molecular weight complex formed when TSH binds to autoantibodies, primarily IgG anti-TSH antibodies. The complex created by this binding is then too large to reliably interact with the TSH receptors on the follicular cells, leading to a reduction in one-to-one TSH-related effects, ultimately leading towards increased production of TSH in order to successfully stimulate the thyroid. The size of these complexes also makes them clear from the body more slowly than the normal size TSH molecule would be able to. Clinically, however, the patient is euthyroid, as the body is simply upregulating the production of TSH so that despite its decreased affinity for the TSH receptor, it can still produce an appropriate amount of thyroid hormone. Said another way, the total TSH is elevated, and the immunoassay counts this total number, while the TSH receptor, less attuned to these macro TSH molecules, but having a larger number of molecules that they're potentially interacting with, these receptors are triggered at the appropriate frequency, leading to a euthyroid state. This results in a variably, though usually significantly elevated TSH with normal T3 and T4, which mimics and can often be mistaken for subclinical hypothyroidism and may lead to unnecessary treatment with levothyroxine when TSH is greater than 10 or when the patient is pregnant. In this setting, the patient's TSH will remain elevated despite the addition of levothyroxine. Now, the lab has multiple ways to confirm the presence of macro TSH. The easy way is polyethylene glycol precipitation. This uses PEG to treat the serum, which causes high molecular weight molecules to precipitate out during centrifugation, after which the supernatant is sampled. And if there is a significant decrease in TSH, that is evidence of macro TSH. That said, the gold standard is currently gel filtration chromatography, which is a technique specifically designed to separate proteins based on their molecular size and gives the definitive confirmation of macro TSH. Such confirmation can not only help the individual practitioner sleep better at night with a case well diagnosed and appropriately managed, but when appropriately documented, it can also help other practitioners avoid starting unnecessary hormone replacement therapy. An increasingly common interference is vitamin B7 biotin, which is a water-soluble supplement that many patients are using over the counter for the marketed improvement in the health of their hair, skin, and nails. The chance of biotin interference increases in patients who are taking high doses of the supplement, which is typically considered to be around 10 milligrams per day or higher, although some studies have demonstrated a lower threshold depending on the specific assay used. This is made even more problematic by the fact that many patients don't disclose biotin supplementation unless we specifically ask them. Biotin interference occurs in immunoassays that utilize the high-affinity biotin-streptavidin binding system, which is a commonly employed technology in many immunoassays. In a patient with high levels of circulating biotin, the biotin can compete with the biotinylated antibodies for binding sites on streptavidin-coated surfaces, leading to a reduced binding of the antibody-analyte complex, and ultimately resulting in falsely low measurements of TSH in sandwich immunoassays. I mentioned previously that there were additional methods of measuring T3 and T4. One such way is called competitive immunoassay. And while I won't describe the mechanism by which it works here, I can say that the unanticipated elevated biotin can steal, as it were, the limited amount of antibody added to the well and result in falsely elevated measurements of the hormones. Biotin interference can show up as a pattern of low TSH and elevated T3 and T4, which can cause suspicion for hyperthyroidism or thyrotoxicosis, leading to unnecessary investigations such as thyroid scans or radioactive iodine uptake studies, and potentially harmful treatments with antithyroid medications for a condition that the patient doesn't actually have. And again, the main way to identify this interference is by directly asking the patient about any biotin supplementation they might be taking. Some labs may also offer specific assays or protocols to assess for biotin interference, which may or may not be helpful in confirming the diagnosis based basically on whether that would really wind up helping the patient long term. Anti-streptovidin antibodies are endogenous human antibodies that can interfere with immunoassays that utilize the same biotin-streptovidin interaction that we just discussed in the last slide. Clinically, anticipating anti-streptovidin antibody interference can be challenging, as there are no clearly established risk factors for their development. However, prior exposure to streptovidin, which might occur in research settings or through certain medical devices or procedures, is a potential theoretical cause for the formation of these antibodies. The presence of falsely positive TSH receptor antibody results, when not clinically consistent with Graves' disease, might raise suspicion for underlying anti-streptovidin antibody interference. The physiological mechanism of anti-streptovidin antibody interference involves the binding of these endogenous antibodies to the streptovidin used as a reagent in the immunoassay system. This binding can hinder the interaction between biotinylated assay components and streptovidin, as we discussed in the previous slide on biotin interference, leading to inaccurate measurements of the target analyte. The typical alterations in TFT results caused by these antibodies are similar to those seen with biotin interference: falsely low TSH levels in sandwich assays and falsely elevated T3 and T4 levels in competitive assays, without clear symptoms of thyroid disease. In the laboratory, suspicion for anti-streptovidin antibody interference should be considered when unusual or inconsistent TFT patterns are observed, especially if multiple assays that rely on the biotin streptovidin technology yield unexpected results. Comparing the patient's TFT results across different immunoassay platforms, particularly those that do and do not utilize the biotin streptovidin complex, can provide clues to this type of interference. Additionally, the use of specific blocking agents designed to neutralize anti-streptovidin antibodies in the patient's serum can help in identifying this type of interference. A significant change in the measured analyte concentration after the application of these blocking agents would suggest the presence of anti-streptovidin antibodies. Again, this can mimic not only Graves' disease, but also biotin interference. If the patient does not have symptoms of Graves' disease and denies taking biotin, it may be helpful to ask the lab to repeat the test on another analyzer. Anti-ruthenium antibodies can affect immunoassays that used ruthenium as a labeling agent. Roche analyzers, for example, are a brand of analyzers known to regularly use ruthenium-based complexes. The mechanism behind this interference involves these antibodies binding to the ruthenium complex or the ruthenium-labeled antibody that is used in the electrochemiluminescence immunoassay technology employed by Roche. This binding can alter the efficiency of the chemiluminescent reaction, leading to either an increase or decrease in the emitted light signal used to quantify the amount of hormone in the sample. The typical alterations in TFT results caused by anti-ruthenium antibodies include falsely elevated levels of T3 and T4. In some instances, these antibodies have also been reported to cause falsely elevated or even suppressed TSH levels when measured on Roche platforms. Notably, anti-ruthenium antibodies can sometimes mimic the biochemical pattern observed in macro-TSH interference by causing a marked elevation of TSH levels. While the clinician is unlikely to know the brand of analyzer used on this sample in the lab, recognizing these aberrancies in the context of a euthyroid clinical picture and making a call to the lab can help inform the lab that more testing may be warranted. Outside of a previous diagnosis involving anti-ruthenium antibodies, the patient's history is unlikely to be helpful in bringing this possibility to the forefront, as the development of this antibody is usually unclear and is thought to primarily be seen in patients with known autoimmune disease after environmental exposure through food such as broccoli or potatoes, or from dye residues on some clothing. There is also some risk of occupational exposure for people producing certain electronics, using ruthenium as a lab catalyst, or in the refining of platinum. The platform-specific nature of anti-ruthenium antibody interference is the most important diagnostic clue for the lab to use. When this type of interference is suspected due to the unusual results acquired, and it is noted to have been obtained on a Roche analyzer, repeating the thyroid function test on an analyzer from a different manufacturer that does not use ruthenium-based technology, such as Siemens, Abbott, or Beckman, can also often help resolve the discrepancy and reveal the patient's true thyroid hormone levels. Thyroid hormone autoantibodies, including anti-T3 and anti-T4 antibodies, are frequently detected in patients with autoimmune thyroid diseases such as Hashimoto's thyroiditis and Graves' disease. Clinicians should consider thyroid hormone autoantibodies as a potential cause of interference when patients with known or suspected autoimmune thyroid disease present with unexpected or rapidly fluctuating TFT results that do not correlate well with their clinical presentation. The physiological mechanism of thyroid hormone autoantibody interference involves these antibodies binding to both endogenous T3 and T4 present in the patient's serum, as well as to the labeled hormones that are used in the immunoassay. This disrupts the equilibrium of the antigen-antibody reaction within the assay, leading to either falsely elevated or falsely low measurements of thyroid hormones. Which way it goes and by how much is influenced by a lot of factors, including the autoantibody's affinity for T3 or T4, its concentration in the serum, and the design of the immunoassay process itself, as one-step immunoassays, where all reagents are added at the same time, are generally more susceptible to interference from these antibodies than two-step assays that include a washing step. A common clue that suggests thyroid hormone autoantibody interference is having persistently high levels of T3 and T4 that don't match the patient's TSH concentration. For example, a patient might have elevated thyroid hormone levels, but a TSH level that is not suppressed, or maybe even an elevated TSH, which is opposite to the expected physiological response. Additionally, significant changes in the amount of T3 or T4 when the same sample is tested on different platforms can also be evidence of this kind of interference. When appropriately suspicious, the presence of anti-T3 and anti-T4 antibodies can be directly confirmed through specific laboratory assays designed to detect these autoantibodies in the patient's serum. Thyroid hormone autoantibody interference can make the interpretation of TFTs particularly challenging, but when keeping an eye out for hormone patterns that don't jive with what we know of thyroid physiology in patients with known autoimmune thyroid disease, we can act on our suspicions and work with the lab to diagnose this additional complicating factor. The final interference we'll look at today is heterophilic antibody interference. Heterophilic antibodies are polyclonal human antibodies that possess the ability to bind to immunoglobulins derived from animal species, and their presence in patient serum can lead to interference in a variety of immunoassays, including TFTs. A common type of this antibody that can cause significant interference is human anti-mouse antibodies, or HAMA, which can react with the mouse monoclonal antibodies frequently used in immunoassay systems. In sandwich immunoassays, heterophilic antibodies can bind to both the capture antibody and the detection antibody, effectively forming a bridge between them even in the absence of the target analyte. This bridging action can lead to falsely elevated results, which is the more commonly observed effect. Less commonly, Heterophilic antibodies can cause falsely low results by directly competing with the analyte for binding to the assay antibodies, thus inhibiting the formation of the normal antibody-analyte complex. Clinicians should be particularly suspicious of heterophilic antibody interference when encountering unexplained and discordant TFT results that do not align with the patient's clinical presentation when the patient has a known history of exposure to animals or has previously received mouse-derived monoclonal antibodies for therapeutic or diagnostic imaging purposes. Phasing out therapies such as muromonimab CD3, which can be used to help prevent kidney transplant rejection, and the current standard of care scintigraphy using an isotope of technetium-99M marketed under the trade name of Sintimun, are some examples of monoclonal antibodies that patients could have been exposed to. In the laboratory, a key indicator of heterophilic antibody interference is the observation of nonlinear results upon serial dilution of the patient's serum. That is, when the patient's serum is diluted, the measured analyte concentration does not decrease in a predictable proportional manner. Significant discrepancies in TFT results when the same patient sample is tested on different immunoassay platforms, particularly those utilizing antibodies from different animal species, can also be a strong indicator of heterophilic antibody interference. A commonly used laboratory technique that's used to identify and neutralize heterophilic antibody interference involves the use of heterophilic antibody blocking tubes, or HBTs. These tubes contain reagents that can bind to and inactivate the heterophilic antibodies in the patient's serum. A substantial change in the measured analyte concentration after treatment with the heterophilic antibody blocking tubes compared to the untreated sample confirms the presence of interfering heterophilic antibodies. The alterations in TFT results caused by heterophilic antibodies can include falsely elevated or falsely low levels of TSH, T3, and T4, depending on the specific assay and the nature of the interfering antibodies. Falsely elevated TSH levels are the more frequently reported manifestation of this type of interference. In conclusion, whether we're talking about interferences, pregnancy, congenital abnormalities, or medications, there are many things beyond simple thyroid disease that can cause deviation from the norm in TFTs. And while the data from the lab can often seem to be the most scientific thing we have, these test results are only fallible tools that have to be interpreted in light of the diagnostician's thorough history and physical exam findings. When evaluating a patient with clinical suspicion for thyroid disease, the presence of symptoms and signs consistent with either hypothyroidism or hyperthyroidism, or no such symptoms as in the case of a simple screening, should guide the initial interpretation of TFT results. However, discrepancies between the clinical picture and the laboratory findings should raise a red flag and prompt consideration of potential assay interferences, which studies have said may have an incidence anywhere from 0.5 to 7% depending on which study you're looking at and which interference you're looking at. These discrepancies can include an elevated TSH with no symptoms of hypothyroidism, or a suppressed TSH with no signs of hyperthyroidism. Unusual patterns in the results, like an isolated elevation of TSH with normal thyroid hormones or rapidly changing results without a clear clinical explanation, should also increase suspicion. Furthermore, clinicians should consider risk factors for specific interferences, such as a history of high-dose biotin intake, which can affect biotin-streptavidin-based assays, or potential exposure to animal antigens, which can lead to heterophilic antibody interferences. Strategies for confirming or excluding interference in this setting include, first and foremost, open communication with the lab. Discussing the specific assays used by the laboratory can provide information about their potential susceptibility to various interferences. The laboratory can also perform additional tests, such as PEG precipitation to detect macro TSH, or specific assays to assess for biotin interference. Another valuable strategy is to request repeat testing of the thyroid function or an alternate immunoassay platform, ideally one that uses a different technology or is known to be less susceptible to this suspected interference. Significant differences in results between platforms can be a strong indicator of interference. In cases where biotin interference is suspected due to supplement use, advising the patient to temporarily discontinue biotin for several days before repeating the testing can help clarify the situation. Finally, utilizing the specific interference blocking reagents such as heterophilic antibody blocking tubes or employing precipitation methods like PEG can help confirm the presence of certain interfering substances. And frankly, these details are primarily important as an introduction to these kinds of issues. It's not on the clinician to chase all of this down. Simply communicating a concern to the pathologist about unexpected results and the possibility of interferences should be enough to get the ball rolling in determining what it is that happened. However it's done, a systematic approach that integrates careful clinical correlation with targeted laboratory investigation is essential to effectively evaluate discordant TFT results and avoid potential misdiagnoses and mismanagement, and give our patients the best care that we can. Thank you very much for listening to my presentation. These were my primary sources for this presentation.